Good morning, everyone. Today we are going to discuss the technology table scenarios. We are starting with BPE related technologies. We have a trainee, and thank you for agreeing to record, which is very good for your own revision and also for the others to revise the subject. Okay. You have 60-year-old gentleman presented with moderate urinary symptoms. His IPS score is 22 out of 35 with a quality of life 5 out of 6. He is quite fit and well otherwise, no significant medical history. What investigations you will do when he attends the clinic?
When this man attends a clinic, I will ask him to attend with a full bladder so that he can produce a urine sample for urine dipstick analysis. And if this is showing evidence of infection, then this can be sent off for midstream urine sample can be sent for culture. I will also ask for uroflowmetry and measurement of a residual bladder volume, and ideally, I will ask for 2 measurements of this.
Okay, regarding the urine dipstick, what is the principle, how it works?
So this works on the principle that the urine dipstick strip and each square contains a chemical reagent, which then induces a color change when it comes into contact with the urine. These are through chemical reactions.
So, what are all the things you can identify by using urine dipstick?
So this can identify the urinary pH, the presence of blood, leukocytes, nitrites, protein, ketones, glucose, and the urine's specific gravity.
Okay, the other things which you left are bilirubin and urobilinogen. Regarding nitrates, it's also leukocytes and nitrates. What is the way by which you can identify infection by using a urine dipstick?
So infection the two main substrates identified are the presence of leukocytes and nitrites. Nitrites are produced by gram-negative bacteria convert urinary nitrates into nitrates. And then there is also the presence of leukocytes, and those are the two main markers.
Okay. Regarding the blood, what is the mechanism by which the blood is detected?
This is detected through hemoglobin producing the enzyme peroxidase, and this causes an oxidative reaction with orthotolidine, which is the substrate on the strip, and this induces cell lysis with a resultant color change on the strip to blue or green.
Okay. Do you know the sensitivity or specificity of diagnosing non-visible hematuria with urine dipstick?
The sensitivity is 80%, specificity is 90%.
Okay. It's just the other way. Usually sensitivity is more than specificity. So sensitivity is 90%, specificity is 65 to 80%.
Okay.
That's good. How the uroflowmetry works?
Sorry, can you repeat the question?
Yeah, you said you will do uroflowmetry for him. How it works?
So there are 3 types of, so uroflowmetry will produce a graphical printout of a patient's flow, which is measured in mils per second, and it measures it against the x-axis, which is the time in seconds. It'll help determine what the maximum flow rate is, provided that a minimum voided volume is produced. And it will also give an idea as to the length of time the patient is voiding, as well as the likely pattern.
Okay, so what are all the parameters you will be measuring in uroflowmetry?
So I will measure the minimum voided volume, the maximum flow rate in mils per second, at the average flow rate, the time taken to void, and there will also be measurements of the residual bladder volume.
Okay, you can also measure the flow time and time to Qmax. Not everything is useful in general practice. Maybe voided volume is important, Q max is important, Q average is not much important, because if there is a hesitancy, the Q average will be quite a erroneous one. So sometimes they can give a Euroflow pattern and ask you to interpret in the technology table also. Say for example, you need to do urodynamics for a patient with male LUTS. How will you plan?
So I'll counsel the patient about the procedure, and I'll counsel them using a BAUS procedure-specific consent form and patient information leaflets. I will explain to them that it's a procedure done under a local anaesthetic with them awake, involving insertion of urethral and rectal lines in order to obtain pressure readings of the detrusor muscle in the filling and voiding phases. I'll explain that it takes approximately 30 minutes, and I'll outline the risks, including bleeding, UTI, the need for repeat tests, and dysuria. And I'll also ensure that the patient has the appropriate instructions prior to the tests, including cessation of any anticholinergics, beta-3 agonists, or prostatic medication, so as to gain an accurate result.
Okay. Can you read the scarred urodynamic tracing?
So I'll ensure that I have a clinical history to hand as well. So during the So in the filling phase, the abdominal vesical lines look to be well subtracted. The bladder, the detrusor muscle appears, there are possibly a couple of detrusor overactivity contractions, but they're not of a high amplitude. Looking at the voiding phase, there's a marked increase in vesical pressure with a stable abdominal pressure. And these appearances would be in keeping with the bladder outflow obstruction.
Okay. If you see that couple of contractions which you're expecting, in PDET, it's flat. So there is no detrusor contraction, and it's only in the P abdomen and P vesicle, and corresponding to that in the top you can see it is marked at CO. So it could be the cough test, just to make sure the lines are intact. So PDET is quite flat, so the filling phase is quite normal. Okay?
Yeah.
Yeah. And how will you set zero pressure when you're doing urodynamics?
So I'll ensure that the lines are flushed. I'll ensure that the transducer is at the height of the upper border of the pubic symphysis, and also that the transducer is zeroed to air.
Okay, so it is zeroed to the superior border of the pubic symphysis. Okay. Is there any role for truss volume measurement of prostate?
So the prostatic, so there isn't a routine role in urodynamics, and prostate volume has been associated with a risk of progression, but it's not, I don't routinely carry it out in my practice, and I'm guided more by the LUTs and PSA and severity of LUTs.
Okay, how the ultrasound works in a truss machine?
So with a truss machine, a probe is inserted transrectally, which and the tip of the probe contains an ultrasound transducer. This will produce ultrasound waves which reflect back off the prostatic tissue, and this returns the transducer and produces an electrical signal. From the truss of the prostate, this can gain information about the size of the prostate, as well as the presence of the seminal vesicles, and the bladder can be visualized too.
Okay. For all the questions, I will always create a kind of like a keywords. So for this question of how the trust machine works, the main keywords are piezoelectric crystal, and the one which you said, that ultrasound wave, electric energy waves, etc. The third one is the waves can be transmitted, refracted, absorbed, and reflected. So how you can explain is, when during the ultrasound, when the electricity applied across to the piezoelectric crystals, it produces a ultrasound wave. The ultrasound wave crosses the patient's body, and then it can be transmitted into the body, or refracted, or absorbed, or reflected. So only the reflected part is taken back by the ultrasound probe and converted into electric energy, which is again we are able to see it in the monitor. So try to bring the keywords like piezoelectric crystals.
Okay, so that question is referring to ultrasound in general as well.
In general as well. I mean, even the
Okay.
truss machine, how it works means you need to bring the piezoelectric crystal into your exam answer
Yeah.
one way or another. Do you know what is the frequency of the truss probe?
The usual frequency of this is 7.5 megahertz.
What is the importance of the frequency? What happens with the frequency is low or frequency is high?
The It allows different tissues of different densities to be identified more readily. So a I don't know beyond that. I can't recall it.
Yeah, it's like if the frequency is high, the depth of penetration of the ultrasound wave is less. So, for example, for prostate, we are using 7 megahertz. If you are going to do ultrasound for the small parts like testes or scrotum, you may require much more higher frequency, like 10 megahertz or even up to 12. That will give you the surface anatomy and less penetration. But if you have to image a kidney, for example, for a PCNL puncture, you will need only 5 megahertz. So as the frequency increases, the penetration decreases. So high frequency probes needed for the skin and near the skin surface organ examination. Okay, so let us assume this patient in your workout found to have voiding symptoms due to benign prostatic enlargement. What type of surgeries you are going to explain to him? He has already tried alpha blockers and 5 alpha reductase inhibitors. He's not happy with that because of his side effects.
And can I ask what his prostate volume is?
Say 80 cc.
80. Okay. The surgeries that the NICE guidelines recommend offering to him are monopolar TURP, bipolar TURP, monopolar transurethral vaporization of the prostate, UroLift, Rezume, and prostatic artery embolization, and also laser enucleation of the prostate.
Okay, so how will you explain this to him? Say starting from monopolar TURP, how it works.
Specifically with monopolar, so for each procedure, I'll explain to him how the procedure is performed, the overall benefit in improving his LUT and preventing progression. I will outline the difference between each of them in terms of hospital stay, transfusion, and side effects. With monopolar TURP, I'll explain to him that it's a procedure performed under general or spinal anesthesia, with resection of prostatic tissue to create a more open channel. It will require at least an overnight stay with a large catheter to reduce bladder irrigation. And I'll explain to him the kind of more specific side effects, including a 75% chance of retrograde ejaculation, 10 to 15% risk of erectile dysfunction, 2% risk of incontinence, but also if this is a monopolar TURP, then there is a risk of TUR syndrome as well.
Okay, so what are the contraindications for monopolar TURP when you will be looking for a bipolar TURP?
The contraindications would include known chronic hyponatremia, known cardiac failure, and as a relative contraindication would be a prostate volume of greater than 100 cc, because then the resection time potentially is greater and risks TUR syndrome.
Okay. And also patient has these pacemakers or defibrillators, and if there is a extensive foreign body in the hip region bilaterally, these are the situations where you may feel bipolar may be better served for the patient. Regarding the cutting and coagulation, can you explain the settings and what happens to the current and voltage in cutting and coagulation settings?
So in terms of the settings, sorry, are you asking for exact numbers in terms of the current?
Yeah.
Okay. So in my practice, I set the cutting at 140 watts and the coag at 90 watts. In terms of the difference in electricity between them, the cutting setting has got a continuous output of the sine waveform. It has a high frequency, a low voltage, and a high power. It's 100% on, and when it's not in contact, it produces vaporization. The coag setting has got a pulsed output with an intermittent sine waveform. It has a low frequency, high voltage, and a low power. It's 6% on, and when it's not in contact, in the non-contact phase, it produces fulguration.
Okay, and you may be asked to draw, the normal pictures, which is quite commonly available in various books. Okay.
Yeah.
So how the bipolar TURP works?
This works along the principle that the loop itself, each limb, so first of all, it's a coaxial sheet the loop is connected into. Each limb of the loop, so the kind of descending limb of the electrode is the active electrode. The current passes through the loop, and when the loop is in normal saline, this creates plasma, which is a state of matter between liquid and gas, and then the current passes back through the other limb of the loop, which acts as the dispersive plate, and back to the machine.
Okay. And what are the advantages of bipolar TURP?
So this allows for greater hemostasis, thus resulting in less absorption of irrigant fluid into the vasculature. However, because saline is used, it also reduces the risk of TUR syndrome causing dilution or hyponatremia, and the absence of glycine as well, and its potential toxic metabolic effects.
Okay. If you see the evidences published favoring bipolar TURP, there are various other advantages like lower clot retention, lower blood transfusion, shorter irrigation time, shorter catheterization, and less hospitalization.
Yeah.
But if the technician is doing a good job with monopolar, I think they can achieve the same outcome. So the main advantage, as you said, is it's good for people with defibrillators or pacemakers, foreign bodies,
Yeah.
and we just want to keep the current within that loop area. But
Yeah.
having said that, even bipolar TURP, if you do resection more than like 60 minutes or 90 minutes, it can cause TUR syndrome, because TUR syndrome is not just the hyponatremia, it's just the fluid overload also. Okay, what are all the laser options available for this patient?
The available laser options would be holmium laser nucleation with holmium YAG. There's also HoLep using thulium laser, and there is also green light laser vaporization, which uses neodymium YAG and KTP laser.
Okay, what is laser?
So laser is an acronym that stands for light amplification by stimulated emission of radiation.
Okay, how laser beam is generated?
This is generated, first of all, through a series of processes. First of all, pumping occurs where a light source is used to generate energy, a flash lamp. This is applied to a lasing medium, which is a laser crystal and the compound. Next, spontaneous emission occurs where an atom within the crystal is excited. The electron orbiting it decays and releases a photon, which is a packet of light. Next is simultaneous emission, where the photon is internally reflected and collides with other excited atoms to produce more photons. And then finally, there is population inversion, whereby the amount of light generated is greater than that which is absorbed.
Good. So this is how it's easy to frame the answer. If you know the keywords like spontaneous emission, stimulated emission, it's easy to bring it out. Very good. What is the setting for HoLep?
The HoLep settings would be using a 550 micron laser fiber with a power of between 100 to 120 watts.
Okay. So what frequency, what joules you will set up if you are doing a HoLep?
So I'll set the energy at 10 joules and frequency of 10 hertz.
The energy will be around 2 to 3 joules and frequency will be like 18 hertz if not 20 hertz.
Okay.
Good. What is the characteristics of laser beam?
A laser beam is monochromatic. It has a single wavelength which ensures that it's of one color. It's coherent, so the waves travel in phase, and it's also collimated, so the waves travel in a parallel beam and are focused onto the same spot.
Okay, so how will you advise laser safety in the theater? Main precautions?
I'll start off with precautions that be taken preoperatively in terms of laser safety training, formal certification and education, and ensuring there is a responsible laser officer in the theatre. During the operation itself, I'll ensure that I'm using the correct laser fibre and that when I'm not using the laser, it's in the standby setting. And in the theatre itself, I'll minimise the number of staff present. I'll ensure that laser safety goggles are readily available to all staff. And I'll also ensure that the window has laser signage, that the windows have covers, and that the doors can be locked to prevent external staff from coming in.
Why the windows are covered?
This would be to prevent laser beam from going through the window and affecting passers-by.
Yeah, and it can also reflect back into the operating room. Okay. Any latest advances in holmium laser technology?
I'm not aware of any recent advances.
Are you aware of the Moses effect?
No, I'm not, sorry.
Yeah, Moses is a kind of a newer technology in the HoLep. It can be used even for stones also. It uses the laser beam is slightly modulated into two parts. The first part is used to clear the water by creating a small vapor bubble that is known as the Moses effect. And since the water is little bit cleared, the second energy will produce a better efficiency whether you are treating the stone or you are treating the tissues. Slightly more commonly proved in stones compared to tissues, and this requires 120 watt holmium laser machine, and also we need to make sure that the fiber is Moses compatible.
Yeah.
Good. What other minimally invasive surgical options available? Say for example, you said UroLift. How UroLift works?
This works on the basis that the lateral lobes of the prostate are kind of pinned back laterally away from the urethra using implants which consist of two tabs at either end, the tab, which is in the urethra, is made out of, I think I can't remember, the other tab is made out of nitinol in the capsule, and then the string is made out of polyethylene. I think stainless steel is the end, which is within the urethra, and nitinol's on the capsule. And this is avoiding resection of prostatic tissue and theoretically reducing the risk of sexual dysfunction and incontinence.
Do you know what is the size of the implant?
The implant itself is approximately 1 to 1.5 centimeters, and the suture is a 4-0.
Okay, so there are some specific dimensions. Possibly, when you revise this in YouTube, you can get the exact dimensions. For example, nitinol capsular tab is zero point 0.6 into 8 millimeter. The suture is 0.4 millimeter. PET suture, polyethylene tetraphthalate. Stainless steel urethral endpiece is 8 into 1 into 0.5 millimeter. What kind of scope is used to place the UroLift implants?
This is a specific scope produced by the company. It's a rigid. It is a rigid scope, but I don't know any more information about it specifically. But it allows the sutures, the implants to be deployed through it.
Yeah, it's a 20 French sheath, and it's a long scope, so it's 36 centimeters. It's 0 degree, and the telescope is 2.9 millimeter. Do you know any recent advances in the UroLift implants?
So UroLift more recently has been demonstrated to that it could be used in treating men who have an enlarged median lobe, and that it could also have a role in the management of men with acute urinary retention instead of refractory LUTS.
Do you remember the study?
I don't remember the study now.
Yeah, it's a Pulsar study. It's a UK based study. That's why I'm stressing on that. Presented by Mark Rochester in both EAU 2021 and BOUS 2021, quite a latest one.
Yeah.
Apart from this, the UroLift has released two newer generation systems. One is known as ATC system, which is Advanced Tissue Control. It has got a kind of a tip is like a wing-like extensions, which is useful to hold the median lobe and a better firing of the implant. And the UroLift 2 system, we can say it's a second generation one. It has got same ergonomic single trigger. All you have to do is you just have to change the implant introducer. We don't have to waste so much of plastic material, carbon footprint, etc. So that's a second generation UroLift. Both are now available in America. Possibly we'll be starting the trial in UK in 4 to 6 months time. How Rezume works?
This works through the injection of water vapor and steam into the prostate, and this then induces enzymes to be denatured and will cause eventually a necrosis of prostatic tissue. Again, it does not involve resection of prostatic tissue. It does involve post-procedure catheterization and removal of this within 72 hours of the procedure.
Okay, again, keywords are important. You need to bring the words like radio frequency at one point, because Rezume comprises a radio frequency generator and a single use disposable transurethral delivery device. It's a 30-degree cystoscope lens and 4 millimeter lens. This radio frequency, when applied to the inductive coil heater in the generator, it produces thermal energy in the form of water vapor. Water vapor is delivered via the retractable needle. It has got 12 emitter holes. It's like 4 into 3, all 360 degrees, and it's a 9-second burst of the water vapor release, and the depth of needle penetration is approximately 10 millimeter. Upon contact with the tissue, the water vapor condenses and it creates convective energy. This is another key word I wish you all to remember. It is not conduction. The difference between conduction and conduction is the energy transmitted from the one area to other area directly. Say for example, if you heat a pan in a stove, in a burner, in your home, in a kitchen, it literally conducts the heat. Convection means only the heat is conducted, so the amount of necrosis will be much reduced. Why this is important is, the previous failed techniques of transurethral needle ablation, transurethral microwave ablation, they all used conductive technology, but the Rezume uses convection, so
Yeah.
that reduces unnecessary tissue sloughing and ischemic necrosis. It still produces necrosis, but it's not a
Yeah.
ischemic necrosis. It's more of like a necrosis within the transition zone alone. And the beauty is this water vapor will never cross the anatomical planes. So the whole process is contained within the transition zone. Peripheral zone is preserved, and hence the injury to the neurovascular bundle is minimized. And yeah, the studies said that there is a reduction of the prostate volume up to 28.9% in 6 months' time.
Yeah.
How aquablation works?
Aquablation. Sorry, I'm not sure.
Yeah, again, if you just catch the key phrase, keywords, then it's easy to frame the answer. So, aquablation uses the hydrodissection to ablate the prostate parenchyma, and it just ablates only the prostatic parenchyma and spares the collagenous structures like blood vessels, surgical capsule. Hence, a kind of the capsule structure is still maintained, but only the tissue is getting ablated. It has got a targeted high velocity saline stream, and it works real time with the help of transrectal ultrasound guidance. And as the aquablation needle moves, the transrectal ultrasound guidance also moves in a very robotic fashion. So first you need to keep the transrectal ultrasound and mark the area you want to ablate, and then the machine will do the rest of the work. After aquablation, you may need a Foley catheter for kind of drainage like overnight, and light traction may be necessary if there is a bleeding. Sometimes if there is an obvious bleeder, you may need a TURP diathermy device or a low powered laser to get the hemostasis. That's a bit of a disadvantage of aquablation. It needs another energy source for appropriate hemostasis, and it's not completely yet accepted by the NICE, and the machine is costly, and but it is suitable machine for higher size prostate glands. And there are a couple of studies, water 1 and water 2 study. Water 1 done in India, water 2 done in a multinational multi-center study. Maybe those things are for the BPE table, but for technology table, you need to reproduce how aquablation works.
Yeah.
What is iTind?
iTind is the implantation of a tri-pronged metal implant into the prostatic urethra. So it's inserted cystoscopically, and this induces a pressure necrosis on the prostatic lobes, and the device is removed at a later date through a string which exits through the urethra after at the time of the initial insertion.
Yeah, again, the key words are nitinol. So in technology table, you should be able to produce the material by which it made, how it works, etc. So the material is nitinol. So it's kept under direct visualization, and just by the mere separation it creates ischemic necrosis and like Turner Warwick incision type of 3 incisions. And
Yeah.
it's not useful if the median lobe is too big, but glands up to 30 to 40 cc, maybe up to 50 cc, it's a good one. It's left for 5 days. How you can understand this: if iTind, the three prongs can open and create a channel in 5 days, think how the UroLift works. So the UroLift, you have this stainless steel urethral tab which is held quite tight by the pet suture against the fixed nitinol capsular tab. So that creates a constant pressure for weeks and months. So that's why the UroLift has much better outcome, especially if it is appropriately applied, because the UroLift creates that continuous pressure for weeks and months, and whatever the channel you have produced in the UroLift in the immediate post-op will be much better if you do a flexible stroscopy in 3 months time. The only thing is it has to be appropriately fired, and the number of implants used should be quite cautiously used. Overusing the implant, it will be a waste of money. Underusing the implant will result in undertreatment.
Yeah.
Okay, good. I will complete from this. Prostatic artery embolization, I don't think they will ask too much in urology technology because it's mostly done by the intervention radiologist, but you can understand and reproduce the main principles like what type of materials were used in embolization, and other keyword is the volumetric CT scans. That's very important to have a proper CT scan so that we will get acquisition of the arterial anatomy and then the embolization works. So this is the overall summary of whatever the technology related to BPE surgery. Sometimes they can ask medicines. So read about tamsulosin, 5-alpha reductase inhibitors, PDE5 inhibitors. Anyway, you'll be reading this for the BPE table. So what is the mechanism by which it works? There
Yeah.
are sometimes in technology table they've just asked about gentamicin,
Yeah.
because end of the day gentamicin, botox, they're all a part of technology, and so they may ask about the medicines also. Okay,
Yeah.
good. Any specific questions or feedback you have?
Um, no, I think cover the main ones. Obviously, there are the ones which I haven't come across in practice, aquablation and iTind, which I've kind of learned in terms of the keywords. And then I think, will they ask much about, obviously with the different lasers, they'll ask about wavelength penetration and absorptive, clinical uses. But I suppose the settings, a HoLep may be the only one that they ask about. They wouldn't ask about FULEP settings, would they?
No, I think HoLep setting is more standard. I don't think they will ask settings for everything. Monopolar, bipolar settings, and HoLep settings are enough. They may
Yeah.
ask the fiber, like 500 micron fiber, and modulator. They can ask about modulator, what type of modulator,
Yeah.
and they can ask, you can choose which modulator you want to explain, advantages, disadvantages, double irrigation, injury to bladder, etc.
Yeah.
And as far as the Resume, UroLift, iTind, Aquablation, they're all very standard. And it's nice if you can produce some numbers, because if the examiner's key word has that numbers, like the pit suture is 0.4 millimeter, if those numbers are there and if you reproduce, that
Yeah.
produces very good impression with the examiners. And obviously none of the examiner can remember the numbers, but if it is in the keywords and if you are able to reproduce, that will be good, because there are mainly 2 points. One is the raw facts which you need to mug up, and the next one is the keywords. These are the only two things. So start making small notes now itself, with every table, with every scenario, just 4 or 5 keywords on the raw numbers. Like for
Yeah.
example, if you're doing a infertility, what are all the keywords and what are all the numbers, the latest WHO normal sperm parameters. I will strongly advise you guys to check this something like 1 or 2 weeks even before the exam, because
Mm.
WHO is so good in changing these numbers quite frequently. And
Yeah.
sometimes the numbers which you produce may not be even in the examiner's keyword. But if you say that I've checked the WHO website 2 weeks back, this is the numbers, means that shows that you are more practical person, isn't it?
Yeah. Yeah.
Good. Very good. Any other questions?
No. Thank you again.
Very good. So we will try to do the other technology tables with you. We are also doing the same technology with the other trainees. So
Yeah.
follow up the YouTube videos so that we can complete the whole technology maybe in next 5 to 6 days.
Yeah.
Good. Thank you for joining on a Sunday, and wishing you a quiet rest of the weekend, and see you on Tuesday.
Thank you. See you then.
Bye then.
Bye.